Hello, this is Ankur and I am a member of the staff at the Department of Cardiovascular Medicine at the Heart and Vascular Institute at Cleveland Clinic in Cleveland, Ohio. I'm an interventional cardiologist with a focus on coronary and structural heart interventions. I'm also an assistant professor of medicine at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University, also in Cleveland, Ohio. As editor-in-chief of US Cardiology Review, it is my absolute honor and privilege to broadcast Radcliffe Cardiology's first ever podcast series. We at Radcliffe Cardiology aspire these series to be just the right dose of new knowledge and information you need per podcast. US Cardiology Review publishes contemporary reviews on evolving and topical areas in cardiovascular medicine, encompassing all subspecialties within the field: general cardiology, interventional cardiology, electrophysiology, and advanced heart failure and cardiac transplantation. We've also introduced a new section on preventive cardiology and cardiometabolic disorders after I assumed the role of the editor-in-chief of the journal this past year. The podcast series will be the audio format extension of these seminal reviews. Our goal is to deliver the information you need to know at the patient's bedside in a digestible, conversational audio format. Hello, everyone. We have with us a very esteemed guest, Dr. Athena Poppas. Dr. Poppas is the Division Chief of Cardiology at the Warren Alpert School of Medicine of Brown University. She is also the Vice President of the American College of Cardiology, and it is our immense pleasure to have her interview for this podcast to talk a bit more about the article that she contributed to issue 13.1 for US Cardiology Review. The title of the article is "Can Early Management of Hypertension by General Practitioners Improve Outcome?" Dr. Poppas, welcome on the show.
Thank you very much for having me. It's an important topic to discuss.
Yes, as a matter of fact, hypertension, as we know, is the leading modifiable risk factor for cardiovascular disease. And the prevalence is not insignificant. In your paper, you've mentioned that 29% of adults have hypertension, and that number actually goes all the way up to 65% with adults who are age 60 and older. Like you said, it's a very important topic. I'm going to start the interview by asking you, why you think is important to treat hypertension.
Excellent question. As you mentioned, the prevalence is high, and it's one of the known modifiable risk factors for cardiovascular disease, including stroke, MI, and heart failure. And we realize that from a number of studies, at least 25% of events can be attributable directly to hypertension, and it accounts for more cardiovascular deaths than any of the other modifiable risk factors. So working on this is important to improving the health of our patients.
Sure. And I just wanted to ask you about what you think the effect has been, the effect of the recent guidelines which came out, which redefined thresholds for diagnosing benign essential hypertension. How that has impacted the prevalence in your practice, and has it changed practice when it comes to office visits with patients having hypertension as a comorbidity?
Yes, and I think the most recent ACCHA guidelines did lower the thresholds for those, for the definition, and also for those that would need treatment, which we can talk a little bit more about. And in that guideline, they do mention that the overall crude prevalence rate then, if you use a cutoff previously of 140 over 90, was 32% overall, and it increases to 46% if you use the newer cutoff of 130 over 80. So we want to know, we know two questions, of course, with any sort of cutoff is, that increases risk. And then the second piece of information that informed this is treating at that risk, does that lower event rates? And both were true. And this evidence was strong enough to change the guidelines. And as you mentioned, also importantly, the prevalence increases dramatically with age. So similarly, the prevalence will increase with this lower cutoff from the 60% range for those over 65 to 70 to 80% range. And more so, as we know, in people of color. So an important thing for us to work on. And it does matter when we see our patients. They often can be a little confused. There's new data that comes out, and it's really incumbent upon us and to synthesize the new data and keep our patients informed of best practices.
Great. I think that's a great segue into me asking you about, my next question, which is, what are some of the non-pharmacological approaches to managing high blood pressure in the office? It's a question that I get asked frequently by patients, who've had an acute coronary event. And, lo and behold, one of the modifiable risk factors is benign essential hypertension. I think, and, as all of us know, or at least in my experience, our training when it comes to nutrition is, at best mediocre, if not lacking, in our training programs. And I think something societies need to pay more attention to, in my opinion. But, how do you break it down to, practical tips for patients who have high blood pressure and want to, indulge or engage themselves in aggressive risk factor modification? What are some of the dietary recommendations you have for patients?
Yeah, I think this is the really good point, in both in our training and in our probably office practice day to day. We are taught and emphasize more the pharmacologic management than the non-pharmacological lifestyle interventions. Quite honestly, as we all know, it's a lot easier. It's easier for the patient. It's easier for us. The studies are cleaner. Studies in diet are notoriously difficult to control all the factors, so that it's not as pure, as scientific as we'd like. That being said, we have good epidemiologic data that I think when we see our patient, we can very confidently say that lifestyle changes are as, if not more important than the medications. And what I try to tell patients is that this is in addition to, and that it will help medications work better. And since most patients don't want to be on medications, that if they're very aggressive in their diet, activity, and weight loss, they may need less medications. And we can talk a little bit more in detail about that. And we can give them data. There's data that, for example, obesity, up to a third of hypertension is related to that. Same with diet and same with activity. Inactivity can increase your risk by twofold. You can tell patients that, the best blockbuster pill out there is taking a walk every day. I think keeping it understandable and straightforward, because this makes the newspaper regularly and I think can confuse patients. I think the other piece that's helpful, as you said, we don't get as much training. It's hard to sort of cover all this in an office visit when, say, as a cardiologist, we're looking at a number of other risk factors that we're trying to discuss with them. And this is why the team approach is important. So general practitioners know their patients well, if not better than us. They see them regularly and can be working on both primary and secondary prevention. Also, thinking about the team, I will often have our nurse practitioner and advanced practice providers see the patients in follow-up to work in a little more detail and length on some of the non-pharmacologic interventions as well, so that they're hearing it from multiple sources, getting nutrition involved and pharmacy involved, often having them see a nutritionist because I get confused about diets. So again, having an expert on your team to help them. In cardiac rehab, for example, we underutilize that. We know that from our data. And cardiac rehab is more than just exercise. It's also social supports for patients. And they often, at least ours has, and most do, an element of nutritional training and giving patients the tools they need. So you're right, it's a difficult thing to tackle, the lifestyle modifications, but hearing it from your physician, how important it is useful. And then making sure a number of other people are helping communicate and reiterate that message is helpful for me and others.
Yeah, excellent. I think a team approach is, becoming the theme in what we do in cardiology because, like you said, it's integrated with other broad specialties and subspecialties, and the comorbid conditions continue to rise in the patients that we see in our offices. Those are all excellent points. Just to touch base a little bit more on the diet issue, and you have an excellent figure 1 in the article, which is reprinted with permission. It's an article. I think the figure is from the article by Dr. Wenger, in which she talks about all the attributable risks, the attributable individual risks, and you've touched on them. You've touched on obesity. You've touched on physical inactivity, smoking. High blood pressure obviously is the topic of discussion. When it comes to diet, and the American Heart Association is recommending 5 servings of fruits and 3 servings of vegetables. Is there any particular method you use in the office in conveying these recommendations to patients, or do you, again, as you said in the discussion that we just had, bring in a nutritionist to talk more about fruit servings and vegetable servings and polyunsaturated fatty acids, because all these exist and are very well written and elaborated, but I think when it comes to practical tips in implementing that all these interventions in your daily diet, it becomes hard even for me. Like, how do I have 3 servings of vegetables a day is a question I ask myself every day. So I wanted to ask you, is there any practical tip that you offer to patients in how to inculcate these recommendations in their daily routine?
Exactly. Difficult questions, and hard to fit all of that information into 15 minutes. So I tend to, again, I see patients as most cardiologists do, ones with a number of issues to tackle. So I will often open it up and tell them in broad strokes what a heart healthy diet means, or what a DASH diet, for example, for hypertension means, and ask if they have questions. And that way, try to tease out a little bit of where their knowledge gaps are. It's sometimes surprising if you ask a couple follow-up questions. Patients might say, "Oh, I don't use salt at all. There's no salt shaker on the table," for example, if we stay with salt for a second. And then if you ask what they had for breakfast, they had ham and other things that are loaded with salt. So it can start the conversation. Same with fruits and vegetables, asking what they had for breakfast or what they ate yesterday, and then asking them how they tried to involve it. You can start to learn different people, different cultures, different way people cook or don't cook might help. So everybody's a little different, and I find it a little hard to tell people specifically what to do. I think, as you mentioned, which is important, here's some broad groups of what you should try to do for a number of servings of fruits and vegetables, lower salt, lower fat content. And the other thing which I think has become increasingly important is our sort of cultural awareness and health literacy of patients. a number of patients, the health disparities are important. They don't have the same access to fresh fruits and vegetables. And so trying to help them with that, though that starts to get outside of my realm, but at least understanding that might be one of their limitations. And then I feel like I can't solve that all in 15 minutes.
Yes.
But it might be they're going to see a pharmacist, or maybe they're going to see the social worker for help with access to fresh fruits and vegetables. Again, utilizing our nurse practitioners who are very knowledgeable that might have some good tips. And probably everybody has a smartphone these days, and giving them websites, whether it's the ACC CardioSmart or the AHA websites that are scientific and up to date, so they're getting real information that's scientific rather than experts on, I don't know. Social media can be awash with non-experts that people will follow. So I try to steer them in a way they can go read more when they leave the office too.
I'm sure. Yeah, no, those are all excellent comments. I mean, I'm sort of reassuring that it's not only a struggle for me, but I think it's just a struggle in general overall, just incorporate all that information and knowledge for patients in a 15, 20-minute visit. So, again, stressing on the fact that, a heart team approach, not only in the procedural aspect of cardiovascular medicine, but also the preventative aspect of cardiovascular medicine is extremely important. So thank you for elaborating on that aspect. My next,
sure. I think one thing that, can I, just a quick follow-up?
Sure.
You mentioned this, and the more I think about it, I think we all struggle with that, is there's just not enough time to cover everything. But, and there's data that supports just planting the seed or hearing from your physician that names something, smoking cessation or diet or exercise are important, at least plants the seed, and then giving them another option to say, we won't cover all this in 15 minutes, but you planted the seed, and then you've given them directions of where to go get more information to support them. Because I think, in honesty, the best we can do is sort of plant a seed of how important these things are.
Great. I like that. I like that comment, of planting the seed, because, it's also very, it's a philosophical comment, but it's also very relevant and very practical in other aspects of life. Just getting a bit philosophical here, but, just planting the seed is so important, because it's like sending a message out to the universe, okay, here I am, and I'm taking charge of my health and my well-being, and in the hope that the universe will respond. And more often than not, the universe responds. So thank you for that planting the seed comment. I love it. That brings me to my next question, which is the medical management, which is what we're trained to do, is how do you manage blood pressure in the office? What are your agents of choice, the initial first-line agents of choice in someone whom you've just diagnosed with benign essential hypertension? For example, in a 45-year-old versus someone who has had high blood pressure. So this is a two-part question. The second part of the question is someone who's had benign essential hypertension for years, is suboptimally controlled, and the age is about over 75. What are the thresholds, and what are the specific drugs or medicines that you prescribe from the armamentarium of medications that we have available? And also, I'm sure you'll touch on this, but in part, a lot depends on the comorbidities as well. So maybe if you can delve into this for our listeners, that'll be great.
Right. So a number of questions sort of embedded there. The first is that we've lowered the treatment thresholds. And for primary prevention, as you mentioned, you want to use your risk calculator. So when we look at the guidelines, one of the take-home messages, which I found helpful, was looking at patients' risk of events can help determine thresholds. So patients have intermediate risk, and we know that often these risk factors are interrelated, obviously. Then the cutoff of 130 and 80 becomes useful, knowing that normal is now defined at a lower level of 120 over 80. So using that new cutoff and implementing this risk calculator. So if you have a 10-year risk of more than 10%, your blood pressure is over 130/80, that's primary prevention, and secondary prevention, same cutoff, obviously, because you've had the disease. So with that in mind, first, drug choice. People certainly have opinions about this. The guidelines do say there's no clear difference without other comorbidities. We can come back to some of the caveats, obviously, whether you use a thiazide, a calcium channel blocker, ACE inhibitor, ARB. There may not be any one drug that's definitely better than the other. Patients that are older might be a little different. African Americans, patients that have other disease such as heart failure, reduced ejection fraction, obviously you would follow the heart failure guidelines and choose an ACE or an ARB first. Patients that have heart failure, preserved ejection fraction, similarly, diuretics can really be the cornerstone for patients with preserved ejection fraction as well. And I think the other issue is data that combination treatment, low dose combination may work better with fewer side effects. The trade-off, as we all know, is patient compliance. So some of the combination pills, if affordable, are sort of reasonable choices there. So it's really a personalization in some way of the hypertension treatment. Shared decision-making is a term which is used a lot, but a little more difficult to implement, as we know. But having a conversation about the different medications, but emphasizing that treatment's important. Here's the drugs we would choose. Here's the pros and cons to the different medications. And then the last thing you mentioned is the age-related issue. So the goal is still 130/80. It's interesting that the caveat in the guidelines, and I think this is helpful, mentions non-institutionalized ambulatory community dwelling adults. And it's a long sentence, but
it's a mouthful. Yeah.
I think it does mean that we don't have to apply things. Guidelines are meant to guide us, and there's judgment and understanding of a patient's lifestyle and where they are, and whether the risks and benefits of treating that, and the patient's preference of where they are and what they're doing. I think that's a more challenging group. We know that the benefits are higher, but some of the risks are higher, and that's true with most of the geriatric sort of medical treatment that we attempt.
Yeah, no, those are all excellent answers. I mean, I think you touched on all the questions that were embedded in the question that I asked. Typically what I would do is, in a patient who has benign essential hypertension, who does not have diabetes, or I'm just trying to get into comorbidities here, does not have diabetes or heart failure. I usually would pick a combination of a thiazide and dihydropyridine calcium channel antagonist. And my thiazide, my go-to thiazide is usually chlorothalidone. It used to be hydrochlorothiazide, but I've sort of transitioned my practice to prescribing more chlorothalidone than hydrochlorothiazide. And I would give a combination pill, amlodipine. And usually they do come in these combination pills as well. More often than not, you would find these medications in combination pills. What is your comment on that strategy, for thiazide and a dihydropyridine calcium channel antagonist as first-line therapy in patients with high blood pressure?
I think it's a good strategy, and what you're aiming to do is lower the risk of side effects and have adequate treatment effect. There are a few patients that could be controlled with a single agent. And I find that in younger patients, they're maybe a little freaked out that there's, quote, something wrong with them and they need medication. And so if you gave them 2 pills to start with, they might feel overwhelmed, but you can also bring them back frequently and say, we're going to up titrate because we want you to be able to tolerate that and feel better. So starting low and then increasing as you go so they don't develop side effects that make them walk away from the medications. But I think the compliance issue, is really something we all struggle with. And the data is out there that up to a third of patients aren't taking their medications regularly or properly or don't believe it or choose alternative medications instead. So I like your approach. I think that the combination medication, and it's about communicating with the patient that we can increase or decrease or change medications if they're having side effects, but you're going to work with them, that you're not giving a medication and you see them back in a year. And again, this is where the general practitioners are so crucial. They can also work with them and work, as you mentioned, the other comorbidities simultaneously.
Sure. And then, as a closing question to this podcast, and, I think what has been a great interview, so thank you for your time. My closing question is, as the vice president of the American College of Cardiology, which, is a large organization with many cardiologists, where do you see, 1, pain points and 2, opportunities for, a society, for example, like the American College of Cardiology, to have an impact on not only cardiologists, but general practitioners in managing high blood pressure? Do you see that in the form of education? Do you see that in the form of workshops? Because, clearly it's one of the leading modifiable risk factor and a significant effect modifier, if you will, for cardiovascular disease. So maybe your closing comments on that would be great for our listeners.
Yeah, I think that's a good point. We sort of talked about the team approach on an individual level with our patients. And the same is true or should be true on a societal level or group level. So cardiology societies, so the ACC, needs to collaborate. And we work very hard to do that, whether we're coming out with guidelines and try to have other key sister societies and partners involved so that it feels that we're speaking for everyone and we're speaking together as one voice. It's certainly confusing for practitioners or patients if there's different guidelines or opinions out there. So I think the first thing is this collaboration and team approach is the society. So working with ACP, AHA, SCI, ASE, all the other sister societies, so that we're speaking with one voice, whether that's for the guidelines that we're coming out with, the education that we're doing, more collaborative education, I think would be beneficial. I'd like to see us do more things like you're doing here, which is bringing things to someone's home rather than having to just fly to a meeting, webinars, podcasts. There's a lot of ways that people can learn, or asynchronous learning, I guess it's called. So I think in the educational world, in the current era, there's many more opportunities for us to collaborate and educate a broader audience. So I think that collaboration is important, and I think I'd like to see us doing more education together and in sort of new and personalized ways.
Sure. Oh, terrific. This has been a terrific interview. Thank you so much for your time, Dr. Poppas. It was our pleasure and our honor to have you on the show. And, hopefully we can get you back again for our listeners to have some more insights on how the American College of Cardiology at a societal level is making an impact in decreasing the burden of cardiovascular disease. Thanks so much.
Absolutely. Thank you so much for having me. This is really insightful and enjoyable discussion.
Yeah, likewise. Thanks a lot.
Please do not forget to rate, review, and subscribe to Parallax on different podcast platforms, including Spotify, SoundCloud, and iTunes, among others. Share with colleagues and friends on social media, and do give us your feedback. Your support means a lot to us. Thank you so much for listening.